Hello guys, welcome to our channel. Today we will be discussing the rapid revision of the ophthalmology. So this is one of the most important topics. At least we can expect 10 to 15 questions from the ophthalmology. So please do revise these important topics, guys. So before we start to the discussion, those who are new to this channel, please do subscribe and share with your friends. And if you want to avail the notes of the all 19 subjects rapid revision and the Sureshot topics, you can join the Telegram group and DM us. Okay, so let's start the discussion, guys, without late. So daily one scientist we will be discussing, right? So this is Dr. Ridley. So Dr. Ridley contributions to the ophthalmology is he has worked as a chief doctor in the World War II. So during the World War II, there is the firearm injuries or the ballistics injuries. So patients used to have the lens injuries. So patients, some soldiers used to also have the loss of vision, opacity issues. So what he has found out that if there is a lens injury, we can adapt the intraocular lens from the outside. So this is a very not acceptable theory, because whatever when we are going to touch the eye from the foreign object, so there will be a catastrophic destruction will be seen. So that is a belief of the other ophthalmologists, but Dr. Ridley has proved that wrong, and he has first person to operate the patient with the intraocular lens. So his distribution to the intraocular lens, and still today one of the most controversial procedure in the 1940s, today and next 100 year also we can say this is going to be the one of the best surgery that he has discovered, right? So let's start the discussion. So first we will be discussing of the eye layers. Okay, how many eye layers we have? Mostly we have the eye three layers. Okay, and what is the shape of the eye? Eye is not a spherical shape. Eye is the aspherical shape. And where does is it is standing? It is standing in the orbit, right? And what is the nerve that is working on? Optic nerve. Okay, this is two optic nerve, and also it consists of the other three nerves. So these three cranial nerve, like oculomotor nerve and also trochlear nerve. This is the fourth, and also abducens nerve. So all these nerves which will be playing the major role for the eye, whether it is motor or whether it is sensory nerve supply. Next, what are the layers? So first and foremost layer, this is the outermost layer, that is the cornea and the sclera, which will be consisting of the outermost layer. Next layer is the choroid also consists of the iris, ciliary body. Next, the last layer is the retina, which will be consisting of the fovea and also blind spot and optic nerve and the vessels. Neurosensory area is the retina. So these are the some of the important points that you have to take note. And we have the two segments. So this is the posterior segment, this is the anterior segment, and the anterior segment is subdivided as a anterior chamber and the posterior chamber. And this anterior segment consisting of the aqueous humor, and the posterior segment is consisting of the vitreous humor, right? So this is the basic things that you have to take note. And another thing is orbit. When I say the orbit consisting of the four walls, right? So this is like a four walls. So the most vulnerable to have the injury, that is the floor. Okay, floor will be having the most common injury. But what is the most thinnest is the medial is considered as a thinnest type, right? Next, moving on to the cornea. So basic things that we have to learn about the cornea is the what are the layers that the cornea consists, and what is the main functions of the cornea. And corneal disease we will be discussing the further. So first we will be understanding what is the cornea. So cornea, as I said, it is the outermost layer. Okay, it is like a covering. And what is the shape of the cornea? C for cornea and C for convex shape, and it is going to do the converging. And how much is the power of this? So there is plus 43 to plus 44 diopters. So this is the power. Next, it consisting of the six layers. Okay, so first starting with the epithelium. So what is the epithelium? It consisting of, it is a non-keratinized stratified squamous epithelium. Okay, it consisting of the non-keratinized squamous epithelium. Next, it is followed by, there is a Bowman's layer. But the difference is that the epithelial layer can regenerate. Okay, if there is a lesion, it can regenerate back, whereas Bowman's layer, it does not regenerate. It does not regenerate, so that it can cause the scar. So scar can lead to loss of vision. So that is what Bowman's layer. Next, we also have the stroma. Stroma is the largest layer. because it consisting of the collagen, which is type 1, and also it consisting of the keratin sulfate. So what does this keratin sulfate does? It is going to maintain the transparency. It is going to maintain the transparency of the cornea. Next, Duas layer. Duas is the most strongest layer, and this is discovered by the Indian. Okay, this is discovered by the Indian Sikh doctor has described, and that's why it is known as a Duas layer. Next, last layer, that is the Descemet membrane. Descemet membrane. Okay, and Descemet membrane is also have the capacity to regenerate. Followed by, we also have the endothelium, and endothelium is the most active part. Okay, and this is also play the role in the transparency. This is also play the role in the transparency and highly metabolic, and it is going to act. But how, what is the nerve supply of the cornea? So nerve supply of the cornea, so when we touch the cornea, so this is going to send the signal via trigeminal, right? So this is known as a afferent. So once the trigeminal is regenerating, that the touch is happened to the cornea, and it sent to the brain signals, and from the brain the signals will reach the CN7. So that is your facial nerve. So from the facial nerve, so the patient will be having the blink. So this blink is due to orbicularis oculi muscle. That is due to orbicularis oculi muscle. So this is how the supply of the cornea will be seen, right? So this is just basic things that you have to remember. Next, moving on to the refractive errors. In the refractive errors, we have the two types. One is the myopia and other one is the hypermetropia. So generally, whenever we have the normal eye, so how we are going to get, so the power from the cornea, and from the lens we are going to have the image on the retina. So this is the general application that we have for the vision. So whenever this photos we have problem, so what does happen to us generally? So this is going to have the blockage. So these blockage will have the different types of the images. For example, if you have the problem with the myopia, what happens in the myopia? So the image is actually forming in front of the retina. It has to be formed here, but it is actually forming in front of the retina. So the power of the eye, so for this patient the power is increased. So the power of eye is increased. This is what we are going to see. Why this power is increased? Because of the curvature. Because of the curvature that is going to differentiate. So curvature is increased, and also refractive index is increased for the patients of the myopia. And how the lens has to be positioned? So the lens is positioned more anterior. A lens is positioned more anterior side, and the treatment that we can go to do for this patient is concave lens. Okay, when we add the concave lens for this patient, these concave lens is going to position the same image on the retina. Next, hypermetropia. Hypermetropia is completely opposite condition. So what happens in the hypermetropia? So the image is forming behind the retina. Completely it is happening in the behind the retina, right? Here it is opposite, as we said. So what happens in these patients? So there is a power decrease. Power is decreased in these patients. Same as the curvature is decreased. Curvature is decreased, and also refractive index is decreased in these patients, and the position of the lens is posterior. So these are the medical conditions which will be defecting the vision in the patient, and here we can apply the convex lens. But what are the other names that is these conditions is have? Myopia is known as a nearsightedness. Nearsightedness, that means they are able to see the near sight. That is the meaning. It does not meaning that the patient is able to not see the near sight. So the myopia patients is able to see the near sight, but they can't see the far sight. And hypermetropia is known as a far sightedness. It is known as a far sightedness. That means they can see the far sight very good, but they can't see the nearby site. So this is what the names of this myopia and the hypermetropia confusion. Just remember these important points that has been asked. Next, moving on to the astigmatism. Astigmatism means like irregular vision. It could be associated with the myopia or it could be associated with the hypermetropia. So what happening in these patients? In these patients, there is a two images forming. Okay, so there is a two images forming. For example, here you can see, so there is a image on the retina and there is an image in front of the retina. So this is known as a simple myopic astigmatism. Next, so these patients is having the hypermetropia. That means one is forming here and other one is forming behind. So this is simple hypermetropic. And next, what is the compound? Both are forming in front only. One, not even one is forming at the retina. So this is a compound myopic. And same as that compound hypermetropic, both are forming behind the astigmatism of the patients. And next, mixed type, one is behind, one is in front. So this is the mixed type of the astigmatism. And for these patients, those who are suffering from the astigmatism, what is the lens that we can use for this patient? Cylindrical lens. Cylindrical lens. And how you are going to check? Whether you are going to check this is in the vertical axis or in the horizontal axis. Or in the horizontal axis. And what is the image that is asked, guys? This image is known as a Strum's conile. And here we will be discussing of the accommodation. So what does the accommodation will be telling us? So accommodation is going to differentiate how we are going to looking at the close image and how we are going to look at the distant image. That is done by these muscles. One is ciliary muscles and the zonules and also the lens. All this going to play the role when you are looking at the distant and also looking at the closed. For example, you are looking at the photo on the wall and suddenly you are looking at the phone. So how this accommodation changes is happening. Let's see. So for example, in the accommodation, when you are looking at the far object, okay, when you are looking at the far object, your ciliary muscle is going to contract. Once the ciliary muscle is contracted, the zonules is going to relax and curl back. And after that, this lens is going to become rounder. So okay, this is going to become the rounder. And this is what the far vision. When you are looking at the closed object, when you are looking at the closed object, your ciliary muscles is going to contract and this zonules is going to become the tight. Okay, instead of the curling inside, they are going to become the contraction, like becoming the tight. Once they become the tight, the central part of the lens become thicker and steeply curved. So this is how you can see this is going to curved outside. So this is what the closed object that we are going to look. So these both are the changes that is going to happen from the far object to the closed object, right? Next, moving on to the what are the tests that we are going to do for the patients, those who are having the distant vision or the nearby vision patients. So first thing we do for the Snellen chart, this is the most commonly used object and the distance for this is the 6 meters to 20 feet and each letter subtends to the angle of the phi of the arc. So we are going to check the patients 2020, 2025, 2030 until the 2200. Even the patient cannot see this Snellen chart. What we can do for this patient? We can ask the patient, for example, we are looking at this 6 meters, right? 20 feet. What we can tell the patient to move on for the further, right? Further 1 meter. Until the 1 meter we will be accepting. Even after the 1 meter also, if the patient is not seeing after the Snellen chart, if the patient distance is also decreased but the patient can't see, then we'll ask the patients to fingers counting. Okay, finger counting is also not happening, then we are going to do the handshake, okay, in front of the eyes. That is also not happening, then we can go for the light reflex. Okay, then we can go for the light reflex. Until the light reflex, we are going to ask the patient whether the vision is visible or not. Okay, next, Landolt serum. This is used for the illiterate patients and they were going to tell about the openings of the rings of that sides. And Snellen chart, E chart, this is also for the illiterates. They are going to tell the direction where this E is looking at. These three charts we are going to apply for the patients. All right, next, moving on to the some condition. This is known as a presbyopia. This is known as a presbyopia. What does mean by the presbyopia, guys? This is the near vision problem. Okay, the patient is having the near vision error, and for this, most commonly, this is the age related. Okay, more than 40 years, every person is going to have. So this is due to decreased accommodation. This is due to decreased accommodation. And what is the treatment? Treatment is convex lens. Treatment is convex lens for these patients. All right, next, moving on to the some of the tests that you have to take note. Okay, some of the tests which is commonly asked, differentiating of the different types of the tests. For example, tonometer. Okay, tonometer. So this is the Goldman tonometer. This is used for the patients of the glaucoma. All right, next, spectroscopy. Spectroscopy will help us to know about the cornea endothelium. Cornea endothelium count. This is for the cornea endothelium. Next, topography. Okay, topography. And the topography is used for the cornea surface. This is for the cornea surface. Okay, please, these points are important. Next, pachymetry. Pachymetry is for the cornea thickness. This is for the cornea thickness. Next, keratometry. This is for the cornea curvature. This is for the cornea curvature. Next, slit lamp. Slit lamp examination is for the lens and the cataracts. Okay, lens and the cataract. And the skimmers test. Skimmers test is for the dry eyes. Skimmers test is for the dry eye patients like scotians or the patient who is having the dry eye we are going to use. So these are the some of the tests, the names that you have to remember. Okay, next, moving on to the common eye conditions. Image based questions can be expected from these pictures. Okay, so common eye conditions, if you want to remember, the cataracts is one of the most important. And what is the cataract that we are looking at here? So this cataract is known as a sunflower cataract. This is the sunflower cataract. And where, in which patients we are going to see this? And this is seen in the patients of the Wilson's disease. Wilson's disease patients. And the Wilson's disease patients is also have the special feature, that is the KF ring. And KF ring is the copper deposits. And where this is located, this KF ring, this is located in the Descemet membrane. This is located in the Descemet membrane. Right. Next cataract. So this is known as a Christmas cataract. Okay, this is known as a Christmas tree type cataract, and this is seen in the patients of the myotonic dystrophy, autosomal dominant condition, myotonic dystrophy patients. And the location is post-capsular cataract, that is seen. Okay, next, another cataract. This is oil drop cataract. This is the oil drop cataract. Oil drop cataract is seen in the galactosemia. And these patients is having this oil drop is because of the galacticol. Galacticol, the metabolite, is going to cause this. And this one is a reversible, only reversible without the operation, that is the galactosemia, and it can be bilateral at a time also. That is also seen. Next, here you can see this is the another cataract. Like you can see, this is the rosette shapes, right? This is rosette cataract. This rosette cataract is seen in the patients of the trauma. Okay, blunt trauma patients, we are going to see the this type of the cataract, or the fist injury, tennis ball injury, blunt trauma to the eye or lens, that is going to cause the rosette cataract. And if there is a trauma, obviously the patients can have the bleeding, right? And this bleeding is known as a hyphema, and blood is located in the anterior chamber. Okay, aqueous fluid is filled with the blood, that is the hyphema, seen in the trauma patients. This is also seen in the trauma patients. Next, this is also the patient who is suffered from the trauma. Okay, this is also trauma condition, and it is known as a iridodialysis. Iridodialysis, that means this is the iris, right? So iris is detached. Iris is detachment. And if you can see, this is the pupil. Okay, this is also pupil. So the patient can have double diplopia due to the other opening of the iris. So these are the some condition. Next, moving on to the another type of the cataract that you can see. This is the snowflake cataract. This is the snowflake cataract. And this snowflake cataract is seen in the patients of the diabetes type 1. Okay, it is not the type 2, it is the diabetes type 1. And what is the cause of this? This is due to sorbitol. Okay, and also carbamylation of lens crystallines. Consisting of the alpha, beta, gamma crystallines, right? So these crystallines carbamylation is causing this condition, that is a snowflake cataract. Next, we have the different types of the cataracts. For example, nuclear cataract and the cortical cataract. What is the nuclear cataract is doing in this patients? Nuclear cataract means it is a central one. Okay, this is the central one. And here you can see this is the cortical type is mostly associated with the increased aging. Okay, and pre-senile cataract, so there is a pre-senile cataract. So pre-senile cataract is seen in the diabetes mellitus type 2. This is seen in the patients of the diabetes mellitus type 2. And another one type, that is a shield cataract. This is seen in the patients of the atopic dermatitis. This is seen in the patients of the atopic dermatitis. This is the one condition that you can remember. Next, we have the Morgagian cataract. Morgagian cataract is the mature cataract. Okay, this is the hyper mature. Sorry, this is the hyper mature cataract. Why? Because the cortex is also became hydroxylation. This is what the hypermature cataract. This is the seen in the patients of the nuclear cataract. Next, intumescent cataract. This is the mature cataract. Okay, complete the fluid is seen, and below above that there is a immature also. Okay, there is a immature type. This is known as a cuneiform cataract. Early stage of the nuclear complication, this is the cuneiform cataract. All right, next, another picture that you can see here. So this is the vicious ring. This is vicious ring. Again, this is the pupil, which is myotic pupil. This is the myotic that causes the this picture that we can see. This is the imprint of the vicious ring. And this is also seen in the patients of the trauma patients. So these are the some signs that you have to remember no matter what for the patients who is suffered from the trauma. All right, next, once the cataract is developed, cataract can be seen in the different locations, right? We just now discussed it can be in the patients of the posterior, or it could be seen in the anterior also. But these cataract can have the different types of the complications. But what is the surgery that we are going to perform in these patients? The best surgery that we can perform, and the most commonly the performed surgery in this patient, is the extra this is the extra capsular cataract extraction. This is the we are going to perform most commonly. And what is the lens that we can insert in this patient? That is the IOL. Post chamber IOL, posterior chamber IOL is the commonly applied one. And for that we have to do the some test. What are the tests that we can go to perform for this patient? The test name is the biometry. And in the biometry, consisting of the keratometry, right, curvature of the cornea that we have to check, and then a scan we are going to ski sorry a scan. What is mean by the a scan? We are going to check the axial length. Okay, this is going to check the axial length, like diameter of the anterior to posterior. Next, we also check the IOL. Whatever we are inserting the IOL, right, we have to consider this power also. All this will be included in the biometry procedure, and they are associated with the complications. The complications which is associated with this, the most commonly and the most severe, that is considered, sometimes we have to even remove the eye. So that condition is known as a endophthalmitis. Endophthalmitis. So endophthalmitis is a post-operative, and this is considered as a inflammation. And what is the most common cause? The most common cause, if it is presented less than 7 days. Less than 7 days is the staph epidermis. If it is more than 7 days, which is a late, okay, this is due to acne bacteria. a facial acne bacteria. And how the patient will be presented? So the patient will be having loss of vision or the decreased vision, and the patient also having the pus. This is known as a hypopyon in the anterior chamber and the congestion. So how we are going to treat these patients? So the treatment of this patient is depends on the patient vision only. So if the patient is having vision properly, if the patient is having the vision properly, we can go for the intravitreal antibiotics or topical antibiotics plus topical. Intravitreal antibiotics has to be sent for this patient, but the patient vision is completely not present, not even for the light. So then we have to go for the e-viscerization. We have to go for the e-viscerization. What is the e-viscerization? Remove entire eyeball. Remove the eyeball except sclera. Except sclera. So that is a procedure that we are going to perform in this patients. So this is the one of the complication that you have to remember. And some points that you have to take note is the ectopia lentis. So ectopia lentis is associated with the either most commonly due to trauma. So the lens dislocation can happen, and it can be due to Marfan syndrome. In the patients of the Marfan syndrome, it is the superior temporal, the lens location will be. If it is associated with the homocystinuria, so the patient is suffering from the homocystinuria, it could be due to inferior nasal, and there is a dislocation also. So the lens dislocation. So the lens dislocation is seen with the two types. One is the anterior, A for anterior, A for Alport syndrome. Okay, posterior. Posterior is seen with the Lowy syndrome. This is the Lowy syndrome. So these are the examples that you can remember, right? Next, we also have the two cataracts that is seen in the children. One is the infantile, other one is the developmental. In that, the most important one, repeatedly asking question, that is the infantile cataract. And when this is presented less than 1 year of the age. The patient is less than 1 year. And what type that you are going to see here? You are going to see the lamellar type of the cataract. This is the lamellar cataract that we are going to see in these patients. And what is the treatment? Immediately we have to do for the surgery. Immediate surgery that we have to do. And for the patients of the Down syndrome, that is a blue dot cataract. Blue dot cataract we are going to see in the patients of the Down syndrome, but it is not an infantile type. We can at least wait for the more than 1 year also, we can wait for these patients. So these are the some of the points of the cataract that you have to take note. Next, moving on to the glaucoma. So in the patients of the glaucoma, there is a two types of the glaucoma, right? One is the open angle glaucoma and other one is a closure angle glaucoma. So what is mean by the open angle glaucoma and how this glaucoma is actually forming? So we have the ciliary
These are
body,
the important
right?
points
These
and the
ciliary body
diseases that we
which will
have
be
to
producing of
remember
the
in this
aqueous
condition.
humor.
Those who are new to this
So
channel,
this
please do
aqueous
subscribe.
humor has to get out from that place, right? It can't stay the same place. So if you can see, so from the aqueous humor, so these ciliary bodies, so it is producing, and from here it is going to travel from the posterior chamber to the anterior chamber, and from here there is a mesh, that is a trabecular mesh. Okay, so there is a trabecular mesh from the ciliary body, posterior chamber to the anterior chamber, and from there trabecular meshwork, and from the trabecular meshwork it is going to into the Schwann's canal. Okay, this is the Schwann's canal, and from here it is going to enter into the veins. Okay, this is going to enter into the episclera vein. It is going to enter. So this is the route for the aqueous humor to enter into our circulation. So what happens sometimes, either this IOP is not going to enter, or it is going to have the blockage, or it is producing more and more. So that is a problem here. So open angle glaucoma means there is no obstruction at any route until the obstruction at the trabecular meshwork. So that is known as an open angle. So the angle of the passage is open here. That is what the open angle glaucoma. And the primary angle closure glaucoma, if you can observe, so the angle here itself, it is completely closed, right, due to iridis bombae. Iridis bombae means the iris is completely bulging upward, so that the space is narrowed to pass the remaining aqueous humor. So that is what happens in the acute acute closure angle glaucoma. So what are the symptoms that will be differentiating in these patients? So the primary angle glaucoma patients is present with a chronic, okay, not like early. They can be over the time they will be having these changes. That is a very chronic type of the patients will be presented. And here AC chamber, the anterior chamber is wide, so there is no problem here, it is wide, and the patients who is suffered from this patient is the IOP is normal only. Sometimes it is normal and sometimes it is mildly elevated, but over the time these patients can develop the, mostly the patients will be having signs such as bionating signs, bionating sign. So bionating sign means, for example, this is the optic disc, so you are going to see this kind of sign. This is known as a bionating sign that we are going to observe in these patients. Next, patients who is suffering from the primary angle closure glaucoma. This is most commonly seen with the adults, and this is acute condition. On exam, you are going to feel that eye is so hard to palpate, and the IOP is almost more than 40 mmHg. This is more than 40 mmHg, and sometimes the patient can also have the rock hard eye that we are going to feel, right? The fixed dilatation of the pupil that you are going to see in these patients. Next, how we are going to treat these patients. So for the patients of the primary angle glaucoma, simply the problem is in the trabecular meshwork. So what you can do, trabeculectomy you can do, or we can do trabeculoplasty. We can change the shape, right? These are the two options that we have. Next, for the patients is the problem is the iris. What we can do, iridotomy, okay, or we can do iridectomy. For the patients is, it is actually, as I said, it is a chronic condition, so we can actually tell these patients to take the tablets also. So the best drug that we can give for this patient is the latinoprost, that can be used for these patients to decrease the progression. And for the primary angle closure glaucoma, this is the emergency condition. We have only chance, that is the mannitol IV drug. So let's see what are the medications that we use. So we have the different types of the drugs that you can see, and these drug mechanism is simple. Either it has to decrease the production or it has to increase the clearance, right? So this is the only mechanism that has to be given for the drugs. So, so the main action of the prostaglandins is going to be the clearance with help of uveoscleral pathway. This uveoscleral pathway is a minor pathway. So as I said, trabecular meshwork is the major, okay, but it is blocked in these patients. So what we can do, we can go through the route that is the uveoscleral pathway. And what are the drugs? Latinoprost and the bimetoprost. And but this is associated with the side effects. For example, uveitis. So the patient can have the uveitis, and also there is a hypertrichosis. Hypertrichosis. Trichosis means it is a hair growth. So increased hair growth will be seen in this patient. And iris pigmentation. Iris is the pigment that is present. Some of us is having the black, some of us will be having the brown. But when this patient is taking the latinoprost, it can even increase that pigmentation. That is also seen. And also cystoid macular edema. This is also present in these patients. Next, beta blockers. Beta blockers can also decrease the production. Okay, they decrease the production of the aqueous humor. How they are going to decrease? They are going to block the beta channels where in the ciliary bodies, because the production is happening here only, so it can decrease the production. And the side effects that is associated with this one is the BBC, blockage of the nasolacrimal duct. Okay, and another B is the blepharoconjunctivitis, and other C is the corneal anesthesia. Corneal anesthesia. This is only I am telling about the patients who is taking the topical of the beta blockers, because other drugs, other symptoms like if they are taking the orally, bradycardia, bronchospasm, that will be also seen. Next, alpha agonist. What does the alpha agonist will do? It will decrease the production. Okay, it will also decrease the production, and along with that, it will also improve the trabecular flow. It will also improve the trabecular outflow. That is also seen with these drugs, the brimonidine and the apiraclonidine. The side effects associated with the brimonidine is important. It can cause the drowsiness, it can cause the depression, okay, and also it can cause the apnea. Why? Because it is going to cross the blood-brain barrier. So if ever it is crossing the blood-brain barrier, all these symptoms can be associated. So what we can do, we can contraindicate this in the children. And apraclonidine, it can cause the only specific to the eyes. For example, eyelid retraction. It can cause the eyelid retraction, and also follicoconjunctivitis. Follicular conjunctivitis is the another side effects that is associated. Next, carbonic anhydrous. This is also topical. We have dorzolamide or the brinzolamide, and the topical these drugs, the carbonic anhydrous, it will also decrease the production. It will also decrease the production. And the side effects that is associated with this condition is the, if they are taking the oral drugs, they can have the acidosis in the body, metabolic acidosis will be seen, and sometimes the longer the therapy, it can cause the stones and GI upset. And if the patient who is suffering from the liver disease, we should not be giving this drug. It can cause the hyperammonia and the sulfa allergy. Next, cholinergic agents. Cholinergic agents such as pilocarpine. Pilocarpine will do the meiotic. Okay, meiosis will be doing by this cholinergic agents, and it will also increase the trabecular flow. It improves the trabecular flow, especially in the patients of the acute closure glaucoma. Next, coming to the patients, these pilocarpine patients, they have the eyebrow ache. Especially eyebrow ache will be seen in this patient, and rarely retina detachment is also seen. Retina detachment is also seen. And the last drug, that is a rho kinase inhibitors, that is a natrosodil. Natrosodil will also increase the trabecular outflow. It will also increase the trabecular outflow of the patients, and it can cause the, this question is asked, this is known as a corneal verticillata. This is the side effect that is associated with the rho kinase inhibitors. All right. Next, moving on to the another important point that you have to understand here is the uveitis. So uveitis is going to involve, either it could be choroid, either it could be pars plana, or it could be pars plicata and iris inflammation. Okay, so if it is a choroid, it is known as a posterior uveitis. If it is a pars plana, this is an intermediate. Okay, if it is a pars plicata and the iris, this is the anterior type. Overall, the most common type is the anterior. This is the most common type. And in the anterior, we have the specific feature, that is last year question, mutton fat precipitate we are going to see. These mutton precipitates is granulomatous. These are the granulomatous. And in which patients we are going to see? TB and the sarcoidosis. Next, intermediate patient. The sign that you are going to see is the snowbank sign. Snowbank sign. And the posterior, this is due to CMV, or it could be due to toxoplasma. And the specific feature, if you see the fog light appearances, that is the toxoplasma, and the pizza pie appearances, pizza pie appearances, that is the CMV condition. This is the uveitis condition that we are going to see. And the complete uveitis that can be associated, like all the layers, if it is included, that we called as a sympathetic ophthalmia. That is known as a sympathetic ophthalmia. So we will just discuss that sympathetic ophthalmia here. So this is the sympathetic ophthalmia. So for example, the patient is having the injury to the left eye. Okay, left eye is having the trauma. Okay, after 12 weeks, patient can develop the T cell activity. So these T cells is going to produce the antigens, and it is going to attack the right normal eye. Okay, it is going to attack the right normal eye and also left eye. Both eyes are going to be affected by this one. So what is, that's why we have telling that this is actually sympathizing due to the injury of the left eye. This is what the patients will be presented. And what is the treatment that we can do for this patient? Enucleation. We can go for the enucleation. What is meant by the enucleation, guys? We are going to remove the eyeball and also optic nerve. So if both are removed, that is known as a enucleation. Next, moving on to the retinal conditions. So retina has these many layers, right? So the retina consisting of all these important layers. We have from the choroid, retinal pigment layer, rods and cones layer, outer nuclear, outer flexiform, inner nuclear, inner flexiform, ganglion, nerve fiber, and the internal limiting membrane. So mostly, as fortunately, we don't have the question on the layers and the identification, but the conditions is very much important. So first and foremost, that is a diabetic retinopathy. So what is the common cause of this diabetic retinopathy? So this is a microvascular condition, right? So in the capillaries, so there is a loss of pericytes, loss of pericytes. So these pericytes is an like attachment of the capillaries. If this pericytes is lost, so what happens? There is a damage to this microvasculature of the retina. That is what the diabetic retinopathy patients will be having. So diabetic retinopathy patients is having the two phases. Okay. So the first phase is the proliferative. Okay, proliferative. So this is a danger phase. Okay, this is not the first. This is a late stage. And the first stage is the non-proliferative stage. This is the early one, and this early one will be showing the different types of the signs for us. For example, you can see here. So the patient can have this flame shaped, the conditions that is going to be seen, flame shaped results can be seen in the retinal picture, and cotton wool spots, like this cotton wool spots can be seen, or you can see the soft exudates or the hard exudates will be seen. But if ever it is progressed to the proliferative phase, the late phase or the danger phase, what happens in the danger phase? Here you can see, this is what the abnormal vessels, there is a new blood vessels that is happened here. So that is what happens in the patients of the proliferative. If there is a new blood vessels, what happens? Sometimes they may rupture. If they are ruptured, that can cause the blindness for the patients. So proliferative, why it is danger? It is going to cause the neovascularization. Neovascularization. New vessels is seen in this patient. Then coming to the treatment of these patients. What is the treatment that we can give for the patients who is present at early stages? Simply, you have to go for the glycemic control and monitoring of the glucose levels. And proliferative phases, this is already the neovascularization is happened. So for this patient, we can go for the photocoagulation. Okay, photocoagulation and anti-vegetative, okay, vascular growth factor we can block. So these drugs can be also given for the proliferative phases, right? Next, moving on to the hypertensive retinopathy. Hypertensive retinopathy is just stages are asked. So the staging classification is the Keith Wagner classification. So group 1 is actually this is the grade 1. Grade 1 is the arteriolar attenuation, or the grade 2 is the Salus sign, grade 3 is the copper wiring sign, and the grade 4 is papilledema and the silver wiring of the arterioles. Just remember the names, the findings is not so much asking. Next, retinal detachment. Retinal detachment question is also has been repeating, guys. Retinal detachment, we have the rhegmatogenous type and the tractional type and the exudative type. So what is the rhegmatogenous type? So the type 1, this is the high myopia. This is due to high myopia, most common cause. We also discussed in the above slide rhegmatogenous, and where we discussed in the patients of the trauma. So trauma patients can also have this condition. And other way, this can be due to aging patients and also due to cataract surgery. Cataract surgery. This patient is also seen with this condition. And what are the symptoms? So symptoms of this patient is suddenly there is a curtain falling on the vision, curtain falling in front of the eyes, that is seen, and also floaters which will be seen. Next, coming to the tractional type. Tractional type you are going to see in the patients of the diabetes mellitus, okay, and the proliferative retinopathy you are going to see proliferative retinopathy, and also other condition like sickle cell anemia, retinal vein occlusion, these patients also. And the condition that is associated here is a gradual loss of vision. So there is a risk factor also. There is a risk factor like diabetes mellitus, sickle cell anemia that you can see. And another same feature that you are going to see, cut and falling. Cut and falling is common in all the types just by the causes that you can identify. Next, exudative type. Exudative type is a very rare type, and this is associated with the uveitis, okay, such as posterior uveitis, and it can be due to tumors, choroidal tumors, or the metastasis that can be also condition. And the symptoms that is associated, again, cut and falling in front of the eyes that is will be seen, and there is a sudden loss of vision, okay, and very mobile retina. This is very mobile retina. These are the findings of the different types of the retinal detachments. Next, we will be looking at the retinal artery occlusion and the retinal vein occlusion. So the feature that you have to remember, the retinal arterial is going to cause a sudden loss of vision. Why? The main risk factor here is the ischemia. So the artery is occluded due to ischemia. So that's why you are going to see the pale fundus, and this is known as a cherry red spot that is seen. And sudden loss of vision, ischemia, pale fundus with the cherry red spot. Remember, this is the cryo. Next, we have the cravo. So cravo is the patients that is associated with the same. Again, it could be caused due to diabetes mellitus patient, or the patient is having the hypertension. So this is causing the vein occlusion. Okay, vein occlusion. And if the vein is occluded, so this is going to have the proliferation. This is going to have the proliferation, and this proliferation can produce the new vessels. So if this new vessels is ruptured, we are going to see this picture. What is this picture? This is known as a splashed tomato appearances. Why splashed tomato appearances? Because this new vessels is ruptured. Okay, but this patient is not sudden loss of vision. This is a gradual progression. This is a difference between the retinal artery and the vein occlusion. And the question that is asked, in which places you are going to see the serrated spot? That is seen in the patients of the trauma. We are going to see in the patients of the retinal artery occlusion. We are going to see, and also LSD patients. Most common is the Tay-Sachs, followed by the Niemann-Pick, and also Gaucher. Very rarely Sandoff, okay, Sandoff, and metachromatic, and also condition like Berlin's edema. Where you are going to see the Berlin's edema, again, this is also due to trauma patients only. And also very rare, this is not a frequently asked, but in some patients of the methanol poisoning also we can see. Next condition, that is a retinoblastoma. So retinoblastoma patients is, this is the feature that you are going to see. This feature is known as a leukocoria, white pupil reflex. Okay, white pupil reflex. Let's understand what is the retinoblastoma. Retinoblastoma is due to mutation of the RB gene. This is due to RB gene mutation, and this RB gene is present on the chromosome 13q. This is present on the chromosome 13q, and this condition is an autosomal dominant, and this is associated with a two-hit hypothesis. That means if the patient is need to have this condition, there has to be two mutations that has to be followed for the retinoblastoma. And the origin of the retinoblastoma is a neuroblastic cells, and the most common, this is seen in the children only. And the symptoms that is associated with this patient is just now that we discussed, that is a leukocoria, or we can say white pupillary reflex of this patient, and also boop thalamus is also seen. On the biopsy, you are going to see this rosettes. What is this rosettes? Rosettes are known as, guys, these rosettes are known as a Flexner Whitener Steiner rosettes. This is a classical pathognomic sign that you are going to see in this patients. And the treatment is enucleation. Remove the tumor with the optic nerve, and then we can go for the chemotherapy. We can proceed for the patient with the chemotherapy. Vincristine, carboplatin, ethopatide, these are the drugs that we are going to give for this patient. Next, blowout fracture. So what is the blowout fracture that we are seeing here? Especially if there is a tennis ball or the cricket ball in our cricketers, and most commonly it is going to involve the floor is involved, and on the floor if it is presented, there is a tear drop sign of the such structure that is present in the orbit, and it can cause the infraorbital nerve injury. This can cause the infraorbital nerve injury. If it is involved, it can cause the anesthesia to the surrounding area. That is what's seen here. So this is the picture. So the patient is having the injury here. The teardrop sign is seen in this patients. Next, moving on to the trachoma. Okay, before the trachoma, that you have to understand, there are the causes associated with the bacteria also. Okay, so the most common conjunctivitis that is associated with the staph aureus. Staph aureus. This is the most common bacterial type. All right. Next, second most common. This is a mucopurulent type due to gonorrhea patients. Next, it can be due to angular also. Angular type is due to Moraxella. Angular is due to gram-negative bacilli, that is a Moraxella. Next, we also have the Apola conjunctivitis. Apola conjunctivitis. This is due to adenovirus 11, or it could be due to Coxsackie virus, or it could be due to enterovirus 71. Sorry, 70. Okay, these are the some of the condition, and it can be due to picornovirus also. Picornovirus. This Apollo virus is known as a hemorrhagic type. Only hemorrhagic type, and the most common the viral is adenovirus type 11. These are the conditions that can be seen. Next, we have the trichoma. Trichoma is due to chlamydia, atypical bacteria. This is due to chlamydia, and most of the times chlamydia is the serotypes of the ABC. Okay, ABC is causing a E means eye condition, and the trichoma patients is consisting of the different types of the features that you can see here. So they can have the these kind of the granule appearances, this kind of the line that is seen. It is like a healing and at the same time inflammation going, which is known as a arts line, and this is a condition like pits. Okay, the pits that is seen known as a Herbert pits, and the trichoma patients again. What are the features? Sago green follicles, and they can have the trichiasis. Trichiasis means inside of the eyelashes. This can cause the blindness due to irritation of the cornea. Next, we also have the patient can have the eye discharge with congestion of the eye and arts line, and also as we discussed Herbert pits is also seen in this patients. And what is the treatment is simple, safe procedure. We can go for the surgery of what? Surgery for the trichiasis. And A for antibiotics, and the best antibiotics is azithromycin, and this is F for facial cleanliness, E for environment, our surroundings, flies that has to be decreased. So this is the procedure that we can do for this patients. Next condition. So next condition is the vernal conjunctivitis. What is mean by the vernal conjunctivitis? So the name itself tell this is not a association of the bacteria or the virus. Vernal conjunctivitis is seen with the patients of the seasonal allergy, like type 1 allergic reaction, hypersensitivity reaction, especially seen with the boys most commonly who is about the 10 to 15 years, and they are going to have the ropey discharge ropey discharge, plus there is a itching. So itching is also present in these patients, right? So for these patients, you are also going to see specific feature that is confused with the Herbert pits. Herbert pits is the trachoma, and these patients is going to have the Harno-Tantro dots. Harno-Tantro dots that is seen in the patients of the vernal conjunctivitis. It is also known as a spring cataract. And the treatment for this patient is the histamine blockage, okay, antihistamine blockage, and also there is a specific topical that we use for this patient. This antihistamine topical, the name of this topical is the olapatadine. Olapatadine. Plus you can also give the steroids for these patients. Topical, both are topical only has to be given. So this is the vernal conjunctivitis. Next, also association with the conjunctivitis in the children like newborns. Okay, most early, this is due to chemical silver nitrate. Okay, most common is the gonorrhea, and this is the early type, less than 1 week or within the 24 hours only. Most late, more than 1 week, is the chlamydia, but this is the severe type. Chlamydia is the severe type. Newborn causes. Next condition, this is the very frequently, very examiner's most favorite, that is the xerophthalmia. Xerophthalmia is a condition that is associated with a vitamin A deficiency. This is associated with a vitamin A deficiency. And this is the most common cause of the blindness in the children, right? We have the specific classification that you have to take note. ZN, this is known as a night blindness. Night blindness. And this is the most common symptom that the patient will tell us. Next, Z1A. This is the conjunctival xerosis. Conjunctival xerosis. So it is an early stage. We can treat. Next, XIB. B for B. This is a Bitot spots. Bitot spots. So there is a controversy. This is a sign that we can recognize, but this is a sign most pathognomic we can specifically see in these patients. This both signs is looked and treated, like diagnosed by us like doctors. Next, X2. This is the further stage, corneal xerosis. Corneal xerosis. X3A, which is an irreversible condition. The ulcer is formed less than 1/3 of the cornea. X3B, again this is also ulceration progression more than 1/3 of the cornea. And XS is almost scarring, loss of vision. XF, this is involves the fundus. Right, these points are important. How you are going to treat? So we are going to treat on the day 1, on the day 10, and also day 14 as per the dosage of the patients. This is the treatment. So what is the treatment protocol? If the patient is less than 6 months, 50k international units. If the patient is less than more than 6 months to 1 year, then it is going to be 1 lakh international unit. If the patient is more than 1 years to 5 years, then it is a 2 lakhs international units. So depends on the age and the days we are going to give this patients. Okay, this is the treatment protocol. Next, moving on to the some other conditions that you can see here. So these two conditions is also frequently asked. So what are these conditions? So here you are looking at the HSV, herpes simplex virus keratitis. That means cornea inflammation. This is the cornea inflammation. So this is a very painless condition. So the patient is less likely there is a painless, but the patient is having the irritation. Okay, irritation is seen in these patients. Okay, over the time, if it is blocked, it can cause the loss of vision also. Early, it is going to cause the punctuates. Early, it can cause the punctuates. If it is not treated, then like this, dendritic ulcer is formed. Even if you don't treat this as well, it can form the geographic ulcer, like a map. Geographic ulcer is formed in these patients. And what is the treatment? Antiviral. But the thing that you have to remember, steroids are contraindicated. But the same herpes simplex with the necrotizing, then you have to give the steroids. So there is a difference between these two. Next, this is the acanthamoeba. So this is the acanthamoeba condition. In the acanthamoeba, this is the most painful eye condition with the history of the pond water. Also, the patient at the same time is wearing the lens. So this is the condition that you are going to see. Dirty water, pond water, swimming pool with the lens, that is this condition. And this one is known as a ring abscess. Ring abscess. The treatment is Fmge is the topical that you have to give for this patients. Next, what about this condition, guys? This condition is known as a ping vela. Ping vacula. So the ping vacula is the degeneration, is a type of degeneration. Don't confuse this with the other condition like Bitot spot. Next, another two conditions. These are the orbital conditions. Like first one is, you can see this is like a erythema, like pus. This is known as a sty. Sty. So why the sty is seen? Sty is going to involve the hardolium. This is going to involve the hardolium, and it is painful. Patient is having the painful, and pus is seen, erythema is seen, involving of the Zier's glands, involving of the Zier's gland with the Staph aureus infection that is going to cause this inflammation. And the treatment here is the hot compression. Treatment here is the hot compression for the patient. Next condition. This is known as a chalazion. Chalazion. Chalazion means it is kind of a cyst. This cyst is painless, okay, and inner eyelid, and this is due to granulomatous inflammation involving of the meibomian gland. So this is involving of the meibomian gland. Treatment here is a surgery for these patients. Next conditions. Here you can see. So this condition is known as, what is this condition, guys? Keratoconus. Keratoconus. This sign, this V-shaped sign is known as a Munson's sign. Munson's sign. And mostly this patient is having the Fleischner deposits. So Fleischner ring is the copper, but only Fleischner is the patients with the iron deposits. And the treatment here is the riboflavin. So riboflavin treatment can be given for these patients. Topical riboflavin that we can give for these patients. Next, here you can see this is the another condition. This is a pterygium. This is the condition of the pterygium, and this is also degeneration mostly associated with the UV rays, who is having the dust, UV rays exposure, and like triangular shape outgrowth is seen, and it can cause the loss of vision when it is going to block the view, block the pupil. And the treatment is graft, autologous graft has to be put. Next, moving on to the one condition that I wanted to tell here is the band-shaped keratopathy. Band-shaped keratopathy is a type of condition with the calcium deposits. Calcium deposits that is seen in the band-shaped cataract. Sorry, keratopathy. B for band-shaped, B for Bowman's capsule. Bowman's membrane, okay, of the cornea, not the Bowman's capsule. Bowman's capsule is in the kidneys. So this is the Bowman's membrane that you are going to involve the band-shaped calcium deposits. Next, we will be moving on to the most important topics. This is for the extra ocular muscles. So if you can observe here, so there is a three nerves that will be consisting of for the extraocular muscles. So that is third cranial nerve, and the fourth cranial nerve, and the sixth cranial nerve. These are the three nerves that we have: oculomotor, trochlear, and the abducens. So there is a mnemonic that you have to remember. All muscles are third cranial nerve, except LR6 and the SO4. LR6 is the lateral rectus due to sixth nerve, and the superior oblique that is due to fourth cranial nerve. That is the action. Next, coming to the what are the actions. So recti muscle means it is a straight direction, and oblique muscle is the opposite direction. So let's see what are the actions of these muscles. So superior rectus muscle. So superior rectus means upward, it is going to helpful for the elevation of the eye. Next, inferior rectus, again I said these are the straight, inferior means downward, this is for the depression, right? Medial rectus, I don't have to say, I think medial rectus means adduction towards the midline. Next, lateral rectus means abduction towards the sides. Next, other two that is coming is the superior oblique and the inferior oblique. So another point that is important here, we have the common tendinous ring. This common tendinous ring which will be holding of the all these muscles except is the inferior oblique muscle. So common tendinous ring involves all muscles except that is the inferior oblique muscle. What is the action for the inferior oblique and the superior oblique? So inferior oblique and the superior oblique, this is going to have the opposite actions. So this is going to be the superior action. For example, it is going to helpful for the elevation, and this is going to helpful for the depression, right? So these are the muscle action and the nerves that you have to remember. And when we are checking for the patients, we are going to check this way. So as I said, the both are upward, right? Elevation, superior rectus and the inferior oblique, and both downwards, inferior rectus and the superior oblique, medial rectus and the lateral rectus, midline and the side views. So when we are classifying these muscles, we have to have the different types. For example, yoke muscles. What is mean by the yoke muscles? Yoke muscles is a type of version movement. Okay, it is a type of version movement. For example, let's say we have the right medial rectus. So the right medial rectus is looking at the midline, right? So this is in the position of the adduction. Next, on the left side. So on the left side, we are using the lateral rectus. Where it is looking? It is looking the abduction. But this both are looking at which side? Which are looking at the left side. So if you want to look at the same direction, let's see this. So these are the two eyes. So they are looking, this is the left, this is the right. So this is the midline, this is on the lateral side. So these are what the yoke muscles. They are the different combination of the yoke muscles that you have to remember. Another example, let's take. For example, on the right side, the patient is looking at the lateral rectus. That means abduction. Right? On the left side, the patient is looking at the adduction. So they are looking at the what direction? They are looking at this direction. That is what this is the yoke muscles we are discussing. Next, we also have the antagonist. Antagonist. What is the antagonist muscles? They have the opposite action. They have the opposite action, but same eye. Let's say one of the example. Same eye with the opposite action. What are those? Superior rectus and the inferior rectus. Superior rectus and the inferior rectus. Obviously, this is the opposite action in the same eye. Next, we also have the agonist. Same action, okay, and same eye. Tell me the examples. For example, inferior rectus and the superior oblique. Inferior oblique, then the superior rectus. These are the same actions, same muscles. These are the agonist. Next, coming back to the squint. Squint means there would be injury to these patients, or the patient can have the palsy to the nerve injury, or from the congenital also. So before the congenital, you have to know about the cranial nerve palsy. So we have the three types of the cranial nerves, three palsies is present. How these patients will be presented. The third cranial nerve palsy patients, how they are going to present it. As we discussed, it is going to involve all the cranial nerves except superior oblique and the lateral rectus. So the patient can have the ptosis. Okay, so the patient can have the ptosis, and also patient can have all is decreased medial abduction, medial adduction is not forming, that is absent, and also palpebral muscles, levator palpebral muscles is not working, that's why the patient is having the, so ptosis also seen. All these features if you can observe, ptosis is seen, the patient is going towards the lateral rectus. Why? Because lateral rectus is intact, that's why the patient is looking at the lateral rectus. And the muscles like superior rectus, inferior rectus is also disturbed, so patient can't elevate, patient can't depress also. So but the patient is looking at what direction? Patient is looking at the outside and downside, because they can't always elevate also. But the patient is depressing. Why the patient is depressing downward? Because of superior oblique is present. Why looking at the outside? Because of the lateral rectus is intact. So this is how the right cranial nerve pulses will be, the oculomotor will be seen. Next presentation, the right fourth cranial nerve palsy. So fourth cranial nerve means the muscle that is involved here, what? LR6 and the SO4. So this is involving the superior oblique muscle is involved. So the patient who is attached with the superior oblique, they can't do the elevation or the depression, which is missing here. So the patient can't do the depression. The patient can't do the depression. And how the patient will be looking? The patient will be looking the extorsion and also hypertropia. Hypertropia will be seen in these patients. Next, sixth cranial nerve. Sixth cranial nerve is the damage to the lateral rectus. Lateral rectus. So that's why the patient is looking inward. The patient is looking towards the inward, or we can take intorsion. And this is the esotropia. This is the esotropia. These are the three cranial nerve palsies and their defects and the muscles is involvement in these patients. Next, what are the tests that we are going to do? Just the test name is important. This is the Hirschberg's test. This is known as a Hirschberg test. We are going to differentiate, is it the trophia or is it the phoria? Next test name. So this is the prism bar test. This test name is the prism bar test. And here also we are going to use for the how much is the degree of the squint. Next, this is the cover and uncover test. Cover and uncover test. And here you can see this is the disc they are using. This is known as a Maddox disc or the Maddox rod test. Okay, Maddox rod test. Last but not the least, here we are going to discuss about the important points of the visual field defects. So there is a nerve supply that is present right in the eyes. So optic nerve. So optic nerve has a different direction, and also the so as our vision also. So it is going to differentiate. For example, if you can see the optic nerve here has a two components. One is the nasal component, one is the temporal component, and the temporal components the is not going to divide. Okay, so temporal components is going to remain same only entire direction, but the nasal components is going to bifurcate at what location? At the location of the optic chiasma. So this is going to differentiate how the patient will be presented. For example, it could be contralateral or it could be ipsilateral. Let's see one by one. If the patient is having at the defect of the optic nerve, so it is going to present with the patient on the same side only, because there is no bifurcation as yet happened in this patient, right? So the patient can have the monoocular vision loss that will be seen in this patient. Let's say that the patient is having the optic chiasm problem. Optic chiasm problem means the bifurcation phase. If it is a bifurcation is happened here, that means it is going to cause the bitemporal hemianopia. For example, if it is involving the temporal one, it is going to cause the nasal vision block. If it is causing the nasal vision block, it is going to cause the temporal vision. So that's why we have the temporal sides is gone due to the damage to the nasal fibers, that is at the location of the optic chiasm. And next, coming to the optic tract, this is the optic tract, or if the patient is having at the location of the radiation, or the patient is having at these locations, right? This one, this is the optic radiation, or the patient at the lateral geniculate nucleus. All this is going to present as the contralateral hemianopias. Why the contralateral? Because this nasal one and this nasal one is already bifurcated. So that's why the patient is having the contralateral hemianopia. So these are the findings that you have to remember. And the remaining is not that much important because this is a common one asking. And the bitemporal hemianopia is most commonly seen with which condition? If there is a tumor that is compressing pituitary adenoma, this is going to cause this bilateral hemianopia. And frequently there is another question that is also asking dacrocystitis. If the patient is suffering from the dacrocystitis, let's say that the patient is less than 9 months or the patient is more than 9 months, what we have to do for this patient? If it is less than 9 months, we have to do the sac massage for this patient. If the patient is more than 9 months, we can go for the probing with the help of the syringe. If the patient is more than 3 years, we can go for the dacrocystectomy. Dacrocystectomy can be done for this patients. So this is how we are going to do. And this dacrocystorhinostomy, where you are going to put this, actually they are opening at the nasolacrimal duct. When we are doing this surgery, we are going to enter this at the middle meatus. We are going to keep it. Next, some of the lasers we will be seeing ND-YAG. So ND-YAG is used in the so many conditions, but the best conditions that you have to remember is the cataract surgery, especially external capsular surgery we are going to use, and also iridotomy in the closure glaucoma that we can use for these patients. Next one, organ green. Organ green. Organ green is used for the trabeculoplasty. This is for the open angular glaucoma condition. This is the trabeculoplasty. Next, excimer laser. Excimer laser. Excimer is laser is used for the LASIK. Okay, LASIK or intacs. These both are myopic surgeries that we can perform. Next, femtosecond. Femtosecond. Femtosecond is we use for the glass surgeries. Again, this is also for the femtosecond laser assisted surgery. That is for the cataract. That is also for the cataract patients that we are going to use, or the patients who is having this, like who are wishing to have the LASIK through this femtosecond also we can use. So these are the important points that you have to take note about the ophthalmology. Basic questions only is asked most of the times, and you can also refer the previous year examination questions also to just revise the final moment, right? So those who are new to this channel, please do subscribe and share with your friends, guys. And if you want to avail these notes, please do join the Telegram group and DM us. Okay, until then, happy preparation, and don't forget to watch all the videos, guys. I am telling you that these all videos is going to help you a lot. Okay, so please do not miss this sessions, which will be helpful for your final examination. See you in the next video.